Okay, so maybe a little bit of background. First of all, I just want to thank you very much for coming this evening. I'm really pleased that you have shown interest in this topic because I do think it's really, I'm just going to start my timer here. I think it's really important and meaningful work. And the nice thing about perinatal loss is that you often get quite a wide subset of the community. And so you're meeting a lot of people that maybe ordinarily you wouldn't have met. And also their partners as well. So quite often I work either individually or with couples, depending on what they are able to do. So my aim tonight is to kind of make you a little bit more comfortable with working in this area. I've learnt quite a lot from my clients, and so that's part of the reason I wanted to do this talk, and also to show you how I've combined that with the clinical psychology that I know. So as Jonathan said, I've been in the business for a while now, 20 years this year, which is a little bit shocking. And I have a private practice in Randwick, and my colleague Sophie is here tonight, so you want to wave to everybody. Another person that's often in our office is Elle Brake. And we are looking for other buddies, so if anyone's interested, please come and talk to me afterwards. The nice thing about tonight is that one of my clients very, very kindly has let me use some of her illustrations. Her name is Alice, and she lost a baby at 32 weeks gestation. And so during our work together, she was journaling using illustrations. So I'm deeply indebted to her that she's let me display this work today. Just says it all, doesn't it? It's beautiful. Okay, so just to give you a little bit of background about the direction we'll be taking today. So I want to give you a little bit of background on perinatal grief generally, and then the client experience of loss, and a little bit on psychology session content. So that will be given in two different ways. Firstly, looking at the therapy modules that I generally use, and then giving you an idea, sort of chronological order of how it might kind of flow across sessions. Please note though that I tailor very heavily to the individual, so I don't want this to look as if it's a colour by numbers approach, because it certainly is not. At the end, I just want to make a couple of comments on policy as well in the area, and the resources that I've got are ones that I've used and found particularly helpful. So we might talk a little bit about, firstly, what are the types of perinatal loss. And these categories are commonly used. They may change in the future because it's always an area of change. But early miscarriage is often thought of in the first trimester, so in the first 12 weeks gestation, late miscarriage between 12 and 20 weeks gestation, and stillbirth 20 weeks plus, because there is this concept of viability being around 20 weeks gestation. There's also medically advised terminations, and they often take place in the first and second trimesters. So today I really want to focus on that blue box when I'm talking about the cases that we've seen. The cases that I'm presenting today, there's probably about 50 of them, I would say, that fit into this box. But we also do fertility issues, normal mothering, so we deal a lot with postnatal depression and anxiety, abortion. Often, even when women have made a choice that they're quite comfortable with, there'll still be grief and loss associated with that. And neonatal death as well is quite common in our practice. So what's on the slide there would probably be about 20% of our work. So we're a women's health clinic, and we will see people from about age 20 all the way up to 80 plus. Okay, so just some statistics. Early miscarriage, it's quite staggering, the statistics, isn't it? 1 in 4 pregnancies, so that's 103,000 Australian families per year. So I have Samantha from Pink Elephants nodding here, her area of expertise. And late miscarriage is 2 in 100 pregnancies, so 6,000 Australian families a year, still quite substantial. And then stillbirth, 1 in 100 pregnancies per year, 3,000 Australian families per year. You might be aware of the recent Senate inquiry with Christina Keneally trying to reduce the stillbirth statistic. Losing a baby is a unique grief, and the reason, there's quite a few reasons. So again, that's one of Alice's lovely drawings. When you're going to have a baby, obviously the expectations are quite high. For a lot of people, things go to plan, right? And a lot of women actually expect that mothering is going to be a wonderful, joyous time, a bit like the Huggies ad. And even with normal mothering, it doesn't always go to plan. So when a tragedy such as this occurs, we're coming from a really high sort of level of expectation, and it's a bit of a cliff face down to shock and grief. It's quite foundation shifting. It's also a form of disenfranchised grief, and I don't know if everybody's aware of that term, but what I mean by that is that there's no real place in society for women to feel supported and discuss these losses. And so there can be quite a strong sense of isolation. Interestingly, also, I know there's some really helpful groups for perinatal loss being run at the moment. I did have one woman, though, who had a medically advised termination, and she was with in a group where it was all stillbirth. And even then she felt a sense of isolation in the grief group. So these different types of loss don't always blend well together. Just to give you an idea as well of what a void looks like, I had a woman who, she was from Germany and she came here and had a partner. They got pregnant and unfortunately they lost the pregnancy, and it created quite a big void for her, because what she was going to do was spend time with the baby. So she'd given up work, and then 6 months later they were moving to Germany. And then when she lost the baby, she had resigned from her job but didn't have the baby to care for, and then it was, well, what do I do now? You know, I don't have a job, I can't fulfil the role of mother. And often these women end up in a time in which there's really no framework or structure, and it's really confronting. So there's a loss of identity and often a loss of self. It's not unusual for women to say to me, I just don't know who I am anymore, and I really don't know if I'm ever going to find that person again. The ongoing triggers are immense. Like it's mind-blowing how many triggers these women are faced with constantly. Obviously they're in that age group in which all of their friends are having babies, right? So there's lots and lots of pregnancy announcements and baby showers, and this is all on top of other anniversary dates and Mother's Day and Father's Day. So it's like a barrage constantly of dates and triggers coming at them. I want you to think about the fact that gestational age and grief intensity do tend to be linked somewhat, but I don't believe there's a high correlation, and certainly some of the early miscarriages can be very, very intense grief. So if someone comes in to see you with an early miscarriage, please go with what their experience is. When you lose a baby, it's not just the baby you know, it's all the hopes and dreams you had for that baby that you're dealing with as well. Okay, so partner differences are there for the very reason that there's biological differences, right? The woman has been the one that's actually carried the baby, and even in same-sex relationships, okay, there is a difference in the grief there for that reason as well. As I said before, I like to work with couples because it gives you a really unique opportunity to hold both of them in mind and to get them to witness each other's grief and to also talk about how they feel. I don't know if you've heard about the dual processing model of grief. Yeah, it's quite an interesting one, and it does talk about different expressions of grief. And it's not uncommon for males to be less expressive, and that doesn't necessarily mean that they're not grieving deeply. So I quite like that model. There's a lot of other good things that model says. You want to be normalising those different reactions and the different emotional expressions as well. And it's a really unique time to be working on communication issues, because some of these may have even been long-standing in their relationship. So you've got the opportunity there to get one partner to be asking the other partner for what they need. So to give you an example, it might be, you know, when I'm crying, it would be really helpful if you could just come and give me a cuddle. And then that's really quite specific, and when the partner actually does that, they feel a sense of, I've helped. For some people, that's not the answer. They might say, I need you to come to me so I can say, yes, I need a hug, or no, I need some space. So it depends on the individual. This sort of loss, I'm sure most losses are physical, mental, emotional and spiritual. Let's have a look at the physical responses, and you'll see that these are like really real changes in the body. So this is a woman that was pregnant and is no longer pregnant. So we've got real hormonal changes. If it's a late stage pregnancy loss, there's going to be a difference in the appearance of the woman. And that's extra challenging, because if she's going back into work and clients she hasn't seen for a long time, they're going to say, oh, wow, you've had the baby, right? So there's a lot of very difficult first meetings. There's physical recovery. So these women, either they've been through a spontaneous miscarriage or had to go through a D&C procedure, or they've had to birth naturally or via caesarean, or vaginally or via caesarean. So all of these things are real physical recovery that they have to go through. Lactation suppression is also a thing, particularly in the later stages of pregnancy or stillbirth. Interesting, one woman said to me that she was trying to wean very gradually after a stillbirth, and people were coming up and giving her really robust hugs, and it's really painful, right? Something to think about. So the physical exhaustion is real as well. In any sort of grief that I see it as a common symptom. Sometimes people just can't get out of bed, and that's okay. You know, don't panic. It's just your body really being out of equilibrium at the moment, and we've got to be patient with the body and mind. I like you to be aware of the actual physical symptoms of grief. I quite encourage people to look at appetite, sleep and digestion as a starting point. And the reason I like to do that is because if those things aren't working, it's very hard to build on, right? And there are real things that you can do as a clinician or whatever specialty area you have. And it's good to have a GP involved or a medical professional, because there might be some other physical factors that are exacerbating their presentation. So low iron levels, vitamin B12, thyroid issues, etc. And your GP will have a whole lot of tests that they can run. So the mental response, you can see Alice has got a lovely illustration there. It's really overwhelming. It's a very surreal experience. It's like going along on train tracks, and then all of a sudden you're thrown off those train tracks and onto other train tracks, and you're veering off in a completely different direction. Feels like you're living someone else's life. And the ruminations are really torturous, right? Your head is just absolutely full. And quite often the rumination is around trying to find answers, and quite often there aren't any. Even these women, they go through sometimes autopsies and genetic tests, and there's a long wait on those. Not always is there any answers after that. I do like to say to women that with the rumination, don't be surprised if your mind settles on something like, I did something wrong, it's all my fault. And that's not because it's true. It's kind of like a resting place for your mind. If I take the easy, sort of simple solution, then I can at least stop that constant wheel going around in my head. Nightmares are really common, really vivid nightmares are really common. Scattered brain and memory impairment. I have seen quite a few people lose things constantly over this period of time, have car accidents. So I like to say, please just go slow because your mind's very preoccupied at the moment. The emotional response looks a little bit different to the 5 stages of grief, doesn't it? That Elizabeth Kubler-Ross model, though, was actually misattributed. It came from a book that she wrote on death and dying, and it was written about people approaching their own death, not about people who have lost loved ones. So it doesn't kind of fit very well, right? But you can see all the different things that people can feel, and this is not an exhaustive list at all. These are just things that clients have told me. Interestingly, you can have lots of them all at once in different levels of intensity, so it's a bit like a cocktail. And grief tends to happen in waves. So the old models used to be, you've got to sit down and really do the grief work, really work through it. The dual processing model goes against that, which I quite approve of. So grief tends to happen in waves. Sometimes you're going to be stuck in the mud, then there might be windows of light. And as a clinician, it's quite helpful to help people to maximise those windows of light when they've got the chance, without feeling guilty about that. Quite often there's a lot of philosophical questions. It's a bit like, I quite like this analogy where a cyclone goes through your house and all the furniture's ripped apart and there'll be chairs broken in the corner and tables over on the other side, and you walk into your house and you've got to decide, do I tape all this furniture back together and put it back where it used to go? Do I need new furniture? Do I need a whole new house? Grief like this is foundation shifting, right? There can be questions like, where is she or he? Will I see them again? Are they at peace? Clearly I don't have the answers to these things, but you can do a lot of good just by listening and exploring those questions with them. Quite often they have their own answers if you give them the right questions to get there. So helping as a therapist, what can we do? Thankfully, a lot. So first of all, I'm going to look at what we can do in terms of possible therapy modalities. Above and beyond all of this, it would be great if you could make sure that you're human with the person, more so than anything. It's always the relationship that's the most important thing, more so than what you're doing with them. So quite often when someone comes in week to week, I'll be asking them, how's your week been? What have you been struggling with this week? How can I help? And I'll have, of course, quite a few things that I want to do with them, but I will tailor to them as we go. So it's a bit like, Friday isn't fish night and and Wednesday isn't, steak night. I'm quite happy to mix it up depending on what's needed. So supportive grief counselling is a really big part. Being a witness to the grief, as I said, this is very isolating, going through this sort of grief. Acknowledging this deep loss and listening, not just to respond, but listening to truly understand, because you will learn a lot. I have. Empathising with the person, normalising, because grief is one of those things where it's really quite close to feeling like you're going crazy. So if you can reassure the person that grief just does look a little bit like this, and you'll be able to see changes that you can feed back to them week to week. Often grief goes on for much longer than what people expect or would like, but there are changes, and a lot of my clients say, well, it just feels less heavy, or they can kind of come up with different words as time goes on. And you're also countering that isolation. Compassion-focused therapy has a place. If people aren't very good at this prior to going through grief, it's going to be challenging for them to come up with self-soothing things to say and to nurture themselves through a loss like this. So it is an opportunity to build on those skills with them. Also, you need to have a lot of patience with the body and the mind through this period of time. There's different stages and things change, but as I said before, it can be challenging. Cognitive behavioural therapy also has a place. I don't want you thinking that this isn't the way cognitive therapy should be done anyway, but I think some people think that if you just change things to positive, everything will be fine, right? That's not what we're trying to do here. I use a modified pleasant event schedule, which obviously I don't call pleasant event schedule. It's a time out from grief and allowing you to build on windows of light. So anything the person finds is working for them, let's do a bit more of that. Or what else could they do? Are they more of a social person or more of an active person? Or when their body's got a little bit of energy, what would they like to do with that? Problem solving certainly has its place because life is going on, right? And there's lots of things that come to a head when people can't function for a period of time. Coping with others and preparing for triggers are big areas, and I've got separate slides on that coming up. Coping self-talk, again, is really important. And the cognitive therapy itself is really useful when you start hearing a lot of blame and guilt and shame, then you can really get into cognitive therapy with that. I use ACT as well. There's some really good techniques there. Dropping anchor is a good one. I don't know if you've heard of that one. So it's acknowledging that the body's in pain, but there is a body around that and the body can move. It's quite a nice sort of meditation. Values work is really quite important because, as I said, they change their foundations around this time, their philosophy on life. So it's quite helpful to work out what they want to do in the future with their life. Mindfulness might be part of ACT or it might be separate. I sometimes use attentional control as well, which is a way of just almost a band-aid approach to that constant rumination. And it's a counting exercise. So you can have whatever version you want. The one that I use is counting from 1 to 5 and then starting again and 1 to 6 all the way up to 10. Some people will say start from 100 and subtract by 3s. Anything that taxes the brain so you can get just a little bit of a circuit break from that constant wheel going around in your mind. Anything connecting to the present can sometimes be helpful. Some people can meditate and do breathing. Other people really need to have a space away from their bodies. So they might want to be looking at a leaf in nature and tracing the veins with their eyes, for instance, using their senses. And allowing any of those moments free from grief without guilt can be quite helpful. Distraction also, I think, has a place. So puzzles, audiobooks, movies, music, reading, the list can go on there as well, anything that is helpful. Body work, I think, also is quite good. Massage, exercise, acupuncture, grief yoga. There's an interesting person in the US coming out called Paul Denniston, and he does a lot of grief yoga. And he is connected with David Kessler, who I think is also worth a look. He's a person in the US. He's got connections with Oprah. He's very well researched and he's had his own personal losses and he's very authentic and he's got some online training that I would recommend as well. Quite like his input. It's good also to see grief as an undoing of attachment. So keeping the attachment theory in mind is a good guide as well. And particularly for later losses, a lot of these women have no choice but to hold this baby in mind. This baby is really part of their family, and so it's helpful to help them define what that ongoing relationship is going to be. Not everybody wants that, and you work with what people want, but it's quite common. Psychodynamic therapy might also have a place. I had one woman who lost a baby quite tragically and had to have a medically advised termination at week 19. Her baby didn't have any kidneys, so the condition was non-compatible with life, unfortunately. But she came in to me, she had gotten pregnant the second time, so this was an example of someone that I've had the pleasure of working all the way through with up until subsequent pregnancies as well, and that happens quite commonly. And she said she had a dream where she was pregnant with twins and one baby was thriving and the other baby wasn't. And I was a little bit surprised that she didn't really see the connection there with her own circumstances. So don't be afraid to point things out because they may not be as obvious to people as what you think. Narrative therapy can also be helpful, particularly if someone's had a long history of loss with fertility. It's good to try and come up with a reproductive story with them and to be including their strengths in that story. So a different way is to show you sort of more of a chronological breakdown of what early, ongoing and later sessions might look like. So certainly in the early sessions you want to be doing a lot of listening, a lot of compassionate work, walking alongside them, being a witness to the grief, listening to their story. Obviously the listening to the story bit, it's a gentle exposure really, so you have to go at their pace. Empathising, normalising those ups and downs, those waves, and countering isolation. And then encouraging listening to the body. There will often be a lot of crying, a lot more than what the people are comfortable with experiencing, but it can feel like the body is just dripping and there's no sort of voluntary control over that. So as I mentioned before, helping with body equilibrium can be useful. And any practicalities, helping with arranging meals, admin, and responsibilities with other children. Interestingly, arranging meals and the waves, sometimes there can be times where you actually laugh in session. I know that seems unlikely, but people can have a very dry sense of humour, and there've been some laugh out loud moments during grief, and it's good to normalise those with the people as well, that they're allowed to laugh, and it doesn't mean that I don't think that they love their baby, right? So to give you an example with the arranging meals, there was one woman who I said, is there anyone around you that could help with meals this week, because she was quite exhausted? And she said to me, well, there is my sister-in-law, but she's a terrible cook and we've suffered enough. Right? So there's quite a lot of these very funny moments. And another woman said to me that her mother said to her after her baby died, well, you're going to get a lot of lasagna. You know what death smells like? It smells like lasagna, right? So there's these very sort of dark wit moments. So don't be afraid of sharing those with them. Examples of ongoing sessions. You want to be slowly helping them getting back into the world and creating some structure. It's really quite important when women are in those voids that I mentioned before. Helping them build on those windows of light and self-nurturing and rebuilding the body. And then dealing with the life issues that are happening around. As I said before, the managing other people and preparing for triggers to grief, I'm going to do a little bit on shortly. And then encouraging self-compassionate thinking and small goals in line with values. I had another client who she had recently had a loss, and it was an early loss, but it was a deep grief that she was going through. And she had a friend who had a baby shower, and we were talking about whether or not she really had to be there, because it was going to be very triggering. But what she said to me was that looking at her values, one of her values is being a good friend. And so she really wanted to push herself through that and turn up. And she did, and it was challenging, but she did a good job. And at the end, she felt very proud of herself. So it's good to work with people and work out what goals they want to set for themselves. Sometimes they're unrealistic, and sometimes you might want to kind of say, that could be quite challenging. Have you thought about that? You know, and be the ally. Okay, and examples of later sessions. So returning to work plans is quite a common one. A lot of women go back to work even before they're ready, and the reason they do that is because it's a sense of structure, and it's an area in their life in which they feel like it's not completely untouched, but they've got an identity that they know in the workplace. It's not always an easy transition though, because there's a lot of first meetings, etc. And a lot of women that I'm working with at the moment are using social media more and more to announce that they've had a loss. And I know a long time ago that would have been considered completely inappropriate, but the world's changing, right? And actually it's been quite successful because it's helped them kind of handle all those awkward first moments, and there still is going to be some, but it cuts down on some of them, and it gives people a chance to think about how they want to approach the person and what they want to say. There will still be some deer in the headlights moments, you know, oh my gosh, here's this person with loss, what am I going to say? So you can't get rid of all the awkward moments, unfortunately. So some of them will be approaching another pregnancy, and some of them will be coming to terms with no further pregnancies. Both of those are big areas of work. You want to be picking up on any problematic symptoms that are creeping in, and also looking at that sense of self and seeing whether or not they're starting to find who they are again over time. As I said before, defining ongoing relationship with the lost loved one. And then there's this idea of acceptance, right? And acceptance was one of those things with the 5 stages of grief. Acceptance was at the end. I don't like to think of acceptance in terms of, actually I don't like the word at all, but if we're going to use it, I don't like to think of it in terms of it's okay that this happened. Acceptance to me, if you're going to use it, is I acknowledge this happened and I'm going to make a life of meaning and purpose, and despite that this has happened to me. So again, values work. What do they want to stand for during this period of time? And any future planning that you can help them with different areas of their life. So different domains of life. And finding a new workable philosophy on life. Unfortunately, quite often we're living with ongoing grief. There was a lovely TED talk that I saw recently. I don't know if anybody saw it as well. A lady was talking about how we don't get over grief, we move forward with it. And that's very much the case for a lot of these women. Also, as part of my work, I like to create an emotional first aid kit for women. So that will be something in their phones quite often, like in the notes section, and it'll be helpful things that they've worked through to say to themselves, either through self-compassionate sort of therapy or cognitive therapy, things that have helped them when they've really been stuck in the mud. And also things that they can do, and that might have come from the distraction list, or it might have come from problem solving. And so you can have quite a long workable list where they can read through every time they're feeling quite low and choose from quite a number of different options there. Because when you're in the mud, it's very hard to generate ideas, right? Okay, so a little bit more therapy detail. As I mentioned before, triggers to grief is a big deal. So if you think about, they're going to have different anniversary dates, you know, the date of conception, the date of the birth, and other special dates, like I said before, Mother's Day, Father's Day, etc. And any plans that they'd made, like Oh, I was thinking at Christmas time, we'd be with my family under the Christmas tree with my baby. All of these plans, there's, as soon as people are pregnant, often they plan a long way into the future. So that's why these grief experiences are quite intense. Births of the other babies around them, because they're in the same age group, and autopsy results, tests, lots of tests. Quite often they're waiting for, not always with information. Returning to work, their own fertility and repeated menstruation can even be a trigger if they're trying to conceive. It can be like a little mini grief each month. And then trying to deal with a new pregnancy or no pregnancy. Interestingly, quite often when people get pregnant a second time, there can be a huge amount of anxiety that they're really not expecting. And it's very, very confronting. I had one woman who, it was real, like a real PTSD response, because she had a memory of seeing the fetus not alive on the scan, and every time she sort of thought about a pregnancy, that's where her mind would go. So as soon as she found out she was pregnant, it was very, very triggering. Okay, so coping with others is a big deal. Sometimes in the early stages at least, you've got to help them find the right people to be around. Some people can be exceptionally triggering. I had one father-in-law say to one of my clients, "Oh, it's probably about time for you to go back to the gym now," and kind of comments that, there's no thinking behind there. First meetings are particularly hard. And so helping them plan for those first meetings, or whether it's a social media announcement or an email, you can help there as well. Jealousy and envy of others is really common, and this is for women even who don't have a jealous bone in their body, right? So it can be really quite confronting when other people around them are having these really easy journeys through fertility. It's very confronting. And then if they're able to conceive in a subsequent pregnancy, there's also the difficulty of other people then assuming they're over it. Oh, everyone can breathe a sigh of relief now because we can forget about that episode, right? So this is something from our Instagram account, which isn't just related to perinatal grief, but it does combine a lot of our work. I've quite often asked women, what would you really like people to say to you? And a lot of the non-compassionate stuff comes up here. A lot of people will say, oh, I know exactly how you feel. I lost one, or, and then you get all the stories and then they're traumatised with everybody else's story, right? Or it's time to move on, or you can have another one, or, just be strong. Everything happens for a reason. That's particularly cruel one. Or just silence and ignoring is quite tricky for people. A lot of women take offence to everyone just ignoring that I just lost my baby. And I know it's a well-meaning thing because people don't want to make the person cry or re-traumatise them. But most women that I've spoken to are quite grateful if it's raised. And let me say also, in the early sessions, if the baby was named, please use the baby's name, right? If there's photos of the baby, please, see the photos, because they're beautiful photos, and you want to be able to share the mother's pride in those times. Okay, so there's just some examples of more compassionate responses. Obviously, this is not going to work for everyone. I did have one woman who did not want anyone to say anything, and she was exceptionally angry. You would be running into something quite fierce if you used some of these. But for the most part, the majority of women I've talked to, that's what they would prefer. So a little bit more on subsequent pregnancies. There's most likely to be ongoing grief. I have a lot of women say to me, should I wait to get pregnant, or should I wait till I'm over the grief? And I generally say, look, it's probably going to be complicated now, and it's probably going to be complicated a bit later. So what do you think? And generally there is a preoccupation with conception, and they're quite keen to get pregnant again a lot of the time. Occasionally, if it's been quite a late loss and there's been a caesarean section, there might be a reason not to fall pregnant straight away, or if there's any issues from their recovery previously. But quite often they will move towards another pregnancy quite soon after, and it can just feel like one very long pregnancy then, which is quite challenging as well. These two next points are kind of my clinician pitfalls that I want you to be aware of. A lot of women distance themselves emotionally in subsequent pregnancies, and that's not a voluntary thing. It's completely involuntary. They can do nothing about it. So please don't overly challenge them on that. It's just the way it is. And generally when the baby's born, if everything's gone well, hopefully in the subsequent pregnancy, they do bond quite successfully. At times it takes a little bit more time, and that's okay. Certainly you want to have an overview, so if you're particularly concerned about someone, you want to be thinking about that, but generally it's just typical. The other thing I want you to be aware of is be careful, and I've had my head bitten off, and rightly so, by saying this sort of thing. Mentioning that the subsequent pregnancy is a low-risk pregnancy, and generally it is low risk, but so was the one that they just lost, right? So if it was low risk before, but it was their 100% experience, they're not really going to buy these statistics second time around. And of course helping them support with preparation for the birth and the baby. Some people will not want to buy things or not want to tell people this time around, and that's okay. Quite often they might go to the baby store and pick out everything they want but not bring it home yet, and that's okay. Okay, so a few challenges that you might come across. Clearly there's always personality that can add complexity. So a person in grief will generally be a more extreme version of themselves. So if you've got someone who is generally quite warm and nurturing, they might be able to draw other people around them a little bit better than someone who's generally quite intolerant of other people, particularly if they're saying really awkward, harmful, well-meaning things all the time. It can be quite challenging, and it's hard when you watch people burn bridges with people around them and become more and more isolated. Culture, upbringing, previous experiences with grief will also influence expression of grief. And some of these women, they'll have more than one loss, right? And sometimes they would have lost parents, or, you know, there's lots of complexities that can come up. Complicated grief, I think it's all pretty complicated. Being stuck, though, and in that stage of really not knowing who you are and not being able to find yourself again is quite tricky. And also when they add complex layers to the grief. So as I mentioned before, guilt and shame, and also any thoughts of failure. It's good to work directly with those. Sometimes could the outcome have been different if I'd done something different is a real sticking point as well. And it's good to talk through that in quite a lot of detail. The pain and love is another one that's quite tricky. So I've had, it was a male partner, and he was saying to me, I'm really scared that I'm going to forget my baby if I work through this pain, because the pain is my connection to my baby and the memory of my baby. So I was using David Kessler's approach, which I quite liked, and he was talking about when I'm feeling pain, can that be me feeling love for my baby, and can I be sending that love out to my baby? So it's a different way of connecting with the memory of the baby, so that it's not always through pain. The other thing is also that if you let yourself not feel pain, not that that's always possible, but sometimes people, as I said, really want to do the grief work and really want to maintain that connection with the baby in quite a negative way. You want to give them the permission to smile and laugh and still know that this person loved their baby, and give them permission to do that. The other thing you want to do is to just see whether or not some of these symptoms are getting into the clinical range. So you want to just see, on top of grief, are there anxiety disorders really creeping in, depression, sleep disorders, anger really getting out of control. You want to work with those as well. So just be aware that as time goes on, see how the person's progressing and if there's any sticking points. The other thing is PTSD symptoms. So there can be nightmares and flashbacks, particularly if there's worry about the baby having suffered. And I've had a few, unfortunately, recently where a baby has been born alive and then passed on in the mother's arms, or the father's arms, and that's very, very triggering for obvious reasons. As I said before, even scans can be quite triggering as well. So you want to be listening to their story in as much detail as they can give, because it is a gentle exposure, always at their pace and in their control. And you can use whatever exposure you're comfortable with, whatever therapy modality. Listen to the words they're using and just check whether or not there's some real extreme words that maybe you can talk to them about. And then with the subsequent pregnancies, you want to be working through any triggers. So birth, for a lot of these later stage losses, last time birth meant death, right? So birth is a massive, massive trigger to get through the second time. And I had a woman who was really fearful of going for her scans in a subsequent pregnancy, to the extent that even going on the bus past the hospital was a big deal. So we had to create a hierarchy for her where she could go on the bus and then she could step outside the hospital, and then the next time she might go in and she might walk out, and then she might go into where the scan was with her partner and then come out. So very gradually, in a nice sort of hierarchical way. She could have easily chosen another hospital, by the way, but she didn't want to take the easy way, which I thought was quite impressive, and she did get there. Sometimes people want to change a lot of things the second time around, and I'm quite often writing recommendations to their care team. So it might be things like, for instance, this time I'd rather be on Paddington ward rather than Oxford ward, Royal Hospital for Women, because I've got a lot of memories in the other ward. Or it might be a different care team or a different hospital or a different birth method. Sometimes people want to do a caesarean after a vaginal birth because the vaginal birth is too triggering. And so you work with them any way that you can reduce triggers. Quite often the obstetricians will allow them more frequent scans if that's reassuring. Sometimes it is, sometimes it's not. I had one couple who said to me, I just want time in this pregnancy to feel normal, so they actually cut back on the scans. So it's an individual thing. Okay, and this is the last slide. Geez, you've done well, thank you for your attention. So there's just a couple of points that I want to make, and these aren't necessarily things that I have answers to, but I just want you to think about, and maybe they might even lead to some comments. So as technology is getting better and better, these women have a lot of access to information. The 3D early scans, you see real babies, right? I had a woman who lost twins at 13 weeks, and she said they were real babies, and they are real babies, right? But the vision is very, very much imprinted in her mind. The other thing to think about in terms of scans is there's often a lot of different testing. There's the Harmony test at 10 weeks, and then there might be another scan at nuchal scan about week 11, I think. And then there's the 19-week morphology scan. Sometimes there'll be issues picked up in these early scans, and sometimes there will be issues picked up in the later scans. When there are, women are given a very difficult choice then, and sometimes it's a choice when there isn't any choice as well, whether or not you want to keep this baby or terminate. These decisions are made with love. You know, this is really big stuff for these women. These women love these babies, right? So if someone's been through a medically advised termination, it's such a brave decision because they're ending the pregnancy knowing that they're carrying that suffering for the rest of their lives, right? It's a big deal. The other thing about that time, particularly the 19-week scan, is this viability cutoff of 20 weeks, right? So you've got a very short period of time to make these decisions. If there's any potential suffering, often people want to make those decisions quickly anyway. But this viability cutoff leads to quite a few complexities. So I had one woman who, she had a medically advised termination at 19 weeks, which is not uncommon. And she said it was handled very well at the hospital. It was treated very much like a stillbirth, and it was done as well as possible. She remembers the midwife at the time said to her, "This is going to be a really difficult day. Let's not make it any more difficult." And she really appreciated that really frank comment. So it was dealt with as a stillbirth, but then afterwards it's dealt with as a termination. So this person has gravida 1, which means the number of pregnancies, and parity 0, which means the number of live births. Live births, is that right, Elle? And that can be the same for someone who's had an early miscarriage or someone who's had a later stage medically advised termination and you don't know from that statistic. I think there could be some improvement there potentially. I'm not sure if there's any agreement in the room over that. There was also other tricky things. If there's a termination prior to the 20 weeks, there's no of the same documentation used. So there's no record that this baby was birthed and the baby died. Whereas if the baby is born after the 20-week cutoff, then you have that paperwork, right? For some people, that's a good thing. For other people, that's a bad thing because it means that this baby isn't acknowledged. It's a really tricky area. So I want you to kind of maybe just think a little bit about that and what the implications may be. As I said, I don't have the answers, but I know there's a lot of experience in this room, so I'd be interested to hear what you have to say. And then just finally, these are some of the resources that I have really liked. So they're not just about perinatal loss. There's some really good general grief articles there as well. I quite like the MPsych's lovely little Coping with Grief book. They're in Lane Cove. And then some really good organisations here. All right. So thank you very much.